going to start with India, and roughly 29% of the Indian population lives in poverty. Poverty in an urbanization environment is rampant. It's the chronic disease is the leading cause of death in India, and Americares is at the center of it in partnership. We've been in the country since 2006, or since 1993, but 2006 Americares India was established, working with more than 170 partners in the country and having 7 mobile medical units in the Mumbai slums. And over time, we've served over 140,000 patients within the clinics. So we're going to be talking with 2 people. The first is going to be Shweta Rawat, who is the managing director of the Rural India Supporting Trust. And the Rural India Supporting Trust provide, and I'm going to ask her to talk a little bit about it, but it's to provide an improvement in the quality of life of those people facing challenging situations in India. And they quote, "The aim is to provide equal access to quality health care and education and provide a dignified livelihood for all people regardless of age, gender, caste, or religion." And the mobile health clinics is an important way that they've been supporting it. So let me start by having Shweta come up on the stage. And Shweta is the managing director of the trust, and she's based in the United States and goes back and forth. And with her speaking is going to be Shripad Desai. Shripad is the managing director of Americares India. So, Shripad. So, Shweta, why don't you just start, give us a little bit of background of the trust and then how you see Americares and how you got involved with Americares.
Good morning, everyone. I want to thank Americares again for giving me this opportunity and for having this great convening. The Rural India Support Trust is actually 10 years old this year, and Americares is one of our oldest partners. We've been partnering with them since 2012. And like Steve said, the idea for the trust was to improve access to services across India for education and healthcare, and really provide services in the last mile villages, so to speak. So, and that's why for us, the mobile medical units was a fantastic experiment in the beginning, but it's really become one of the projects that we've scaled up, not just with Americares, but our other partners as well.
So how do you go about the process of choosing a partner, and what are the characteristics that you're looking for in a partnership?
So when we first partnered with Americares, in fact, when I was getting ready for this summit, I was looking at, I have the first proposal that was sent to me in 2012. And at that time, I think you had 1 van running, and they were looking for funding for 2 more vans. And what impressed me even then was the technical research and the study that had already gone into the pilot project. And it was, you know, the viability of it was very strong, and that was very impressive for me. And it allowed us to really put our trust into this organization and say, you know what, they really know what they're doing. And I think this is going to be a great way for us to see whether this project will help the people on the ground. And what also has impressed me in the 7 years that we've partnered with them since is not just Americares' ability to have a great long-lasting relationships, but it's just the technical expertise required to manage, you know, large-scale medicinal distribution, as well as the disaster management component, which we have, through Americares, funded and supported disaster relief in India twice now, I think, most recently being the Kerala floods.
So Shripad, talk a little bit, one of the things, going to let Shripad talk a little bit about not just what's going on with the mobile vans, but he's sort of a little bit of jack of all trades in terms of managing such a wide range of activities in India. Talk a little bit about the range of activities that you're doing, but also how you work with an organization like Shweta's, and how you think about making the dollars go as far as they do.
Sure. So, good morning, everyone. America's India operations is about 90 people now. So when I joined in 2012, we were about 18 people. In terms of programs, yes, we focus on emergency response since emergency has already been spoken about, and we have in the past responded to all major emergencies within the country as well as outside the country, including the Nepal earthquake. I'm proud to say that my team was in Nepal within 48 hours of the earthquake. So that's about the emergency response that we work along. In terms of the developmental programs, we have a very successful mobile health center program now running in the city of Mumbai and other parts of the country. We have a school health program which reaches out to about 30,000 children studying in the municipal schools in Mumbai, and we have a large health workforce safety program which focuses on health system strengthening and ensuring that the health workers are protected from infectious diseases. So that's really the work that we do. Talking about our relationship with RIST or the partnership with RIST, I go back to 2011 when the seed funding from Baxter International actually started the first mobile clinic. And if I have to, I was telling Shweta that if I have to say how the relationship has been, I will say that RIST partnership has been really transformative. Because when we look at the program that started with just launch of one van, today it is a mobile health center model. So it's really evolved, and I love to describe it in four acronyms. You know, I love to call it as ABCD, which means that A stands for access to primary care for the urban poor. So here is a mobile clinic that has a qualified doctor and branded medicines which are offered to the people who are living in the slums of Mumbai. Second important focus is on B, which stands for behavioral change. So our trained health workers work with the communities, educating them on certain health habits. The C is capacity building. As some of you may know, in India, in addition to allopathy, we have other homeopathic medicines and Ayurveda. So there are these practitioners who are not qualified allopathic doctors, but they do exist and they do cater to the population. So the C of the model focuses on capacity building, which means that we are actually investing and building the capacity of this population so that they are able to offer a certain quality of care to the population there. And D finally focuses on the linkages, you know, the referral linkages to the health facilities and the service providers. So as you will see that the model really, which started as one van, has evolved, and I would say thanks to RIST support. If I have to talk about what made this possible, I think RIST we see, because we do work with many partners. The difference, if I have to say about RIST, I think it's more of collaboration, co-creation and shared value. So it is never, I mean, it goes beyond, I don't know whether it's suitable platform, but RIST Americares partnership is beyond writing a check, is what my perception is. They have always been participative, involved. I mean, at operational level, we do have quarterly reviews and monthly calls, but I think we talk more off the call than on the call. So when the RIST team comes in field, they are actually on ground trying to understand what are the real issues, and then we come back and we sit at the drawing board and finding solutions together. I think that's what I would say is the difference that I find.
This whole issue of what makes a good relationship between and the partnership, you've talked a little bit about communications. Shweta, you want to just talk from your perspective on how you view a relationship and what makes a good one, what makes a bad one, and how does it really work in your mind?
Obviously we've been partnering for 7 years, so this is a good relationship for us. The capacity of an organization is one of the first things we look at if I had to give a grant to somebody, and not just the external capacity, but the internal capacity, how the team is, and whether they really have responsive, right people in who we are dealing with on a day-to-day basis. And like Shripad said, transparency is very important, and the willingness to listen. As a grantor, a lot of times when we meet with organizations, there's, especially in India, or I think in developing countries where funding is always a rush and a race to get the right amount of funding. As a grantor, we feel very sensitive, because if we say something or might want to change or tweak the program a little bit in some way, it almost, the grantee feels, oh my God, what if they cut our funding off? What if we don't do this? So with Americares, there's this very open dialogue, and we've sat and talked about our projects together, how we can make them the best version of what they are really, and how we can service the most amount of people and really bring about behavioral change like Shripad mentioned. And we have a very strict monitoring and evaluation policy in the Rural India Support Trust, and not just Americares not just adheres to that policy, but really stays on top of, just even the not so fun things like bringing in the quarterly reports and any kind of, material that we ask of them. So our relationship is very transparent and it really flows very well for us.
And how frequent is the communication between the two organizations?
Quite often, I think. I mean, we have our executive director here, Paul. I think Shripad and Paul talk probably a few
Every
times.
month,
Yeah, at least once a month they check in with each other. And again, things are different. When the Kerala floods happened, I thought of Americares as the first, I knew they would be the first responders on the ground. So immediately my mind was in how do we get the funds to them to start the rescue rehabilitation efforts on the ground.
So this whole issue of transparency, communication, frequency, and when you have poor ones where you've gotten the funding and then they take the money and run basically, you've seen examples of lack of communication as well.
Yes, we've seen examples of lack of communication, lack of responsiveness to what the grantor would request of a program, because it also has to reflect our values. So I think that...
Okay. All right, let's hear anybody in the audience have questions for the two of them. Yes?
Could you restate I got the ABC, I did not hear the D.
The D is developing referral linkages
Okay.
with the healthcare providers and the health posts and the hospital network. So in each of the clinic area that we move in, we've already mapped who are the service providers there, and the community is then linked to them. So this is broadly, if I have to say, it's kind of, you're not going to be there for the lifetime. So the whole strategy works around you move into the community, you start providing them a certain quality of care, and I dare say we're kind of setting expectations from the community. In our absence, the communities go to these, so to say, non-allopathic doctors, and they're paying some money, but they are not getting the desired quality of service. So at one level, what we are doing is, one, we are raising their expectations. We are also supporting them with the behavioral change communication. On the other hand, when we build the healthcare providers, we are actually pushing them to raise their level of service and finally linking them. So that allows me to have a clear entry and exit strategy kind of. So that's the model we are kind of looking at.
Better than they.
Yes, yes.
Another one, any other? We have time for another, yeah.
You said you had a strict sort of M&E policy. What sort of outcomes do you measure?
The question is, what kind of outcomes are you looking at measuring?
So it depends on the project. I mean, when we, for example, with the MMU, in the beginning, we just wanted to look at how many people we were reaching and really look for the behavioral change of people actually pursuing and visiting the doctor. And then as the program changed and started to fill those boxes, we said, okay, the next things we want to really look at is how we can better the program. Let's look at electronic monitoring records and having, like Shripad mentioned, the referral system in place. So I think with Americares now, specifically the mobile medical program, they have a great referral doctor system, so they can actually track the patients who go in for the second level of referral and make sure they're going with the follow-through. And I think the behavioral change, so it depends on the program, but we create certain very visible indicators that would tell us within 3 years if the project is on the right track or not.
Yes. If I can add, we are also now focusing on NCD, hypertension, diabetes. So in each of the community areas, we know how many hypertensive patients are there. So our health workers, when the van goes, they follow up with them, and we are now tracking as to of the number of patients who were hypertensive or diabetics, how many are under control and so on, because these are really hard indicators and outcomes. So we are moving in that direction. So it's it's a combination of some soft indicators and some of hard indicators.